Hello, everyone. Thank you all so much for meeting up today to discuss about our dear friend, Mr. Ali. I presume you all have already read his case?
Yep.
I have been reading about him, and I think it's really unfortunate that he's been going through a lot, isn't it?
Yeah, I really hope that we can find a way to help him.
Mhm.
I was thinking
And
maybe
yeah,
like
we
his
should
mental
definitely talk
status.
about his
Maybe we
dialysis.
can talk about
What
his
about
heart.
the
I
heart
don't know.
thing?
Wait. This is not going to work. Why don't we start with the most pertinent issue first?
I think that we should start with his altered mental status. Is it okay if I share my screen?
Yeah, sure. Tell us more.
Yeah, thank you guys so much for giving us the floor. So the primary issue that we're seeing is that he's disoriented to both time and place. And so he is unaware of where he is and what his treatment has been over the past couple of weeks and why these treatments have been occurring.
We were thinking too about some possible contributors that could be causing this. Our kind of like first one that we want to talk about was the inadequate dialysis. It did mention that they weren't able to pull off as much as they were wanting to. But some other things that could potentially be contributing would be maybe some excess sedation due to his morphine. He might have some electrolyte imbalances going on as well. And then he does have that hypotension during dialysis. So a secondary issue that we kind of identified for this patient is he is not able to consent to a coronary artery bypass surgery, which cardiology has identified as something that could be really beneficial to him and really help with his heart failure. And so at this point, because he is delirious and he does have that confusion, he is not able to consent. And so we really can't recommend that surgery for him until he recovers from the delirium.
Yeah, I couldn't agree more. Another secondary issue that we were thinking of on our team was the lack of participation in treatment and recovery. Lack of participation is going to lead to further deconditioning, which we've already begun to see both in his physical state and his mental state. He's having a hard time even getting out of bed himself. So we definitely will want to bring in OT and PT to mobilize Mr. Ali more, engage him in some activities at the bed level, get him out of bed when we can, even if it's maximum assistance, because any sort of mobility and active engagement is going to help him mentally stimulate as well as physically stimulate, which is going to help maintain his current level of functioning and hopefully start to progress him back to his baseline.
I think that's a great point, Kelly.
Thank you. Another secondary issue that we thought was relevant that might pertain to speech or SLP is the issue of eating, nutrition, and aspiration. Depending on the severity of Mr. Ali's delirium, eating and feeding could definitely be a safety concern for him because he could very well ingest his food down his windpipe, which could then quickly lead to pneumonia. We're going to need to be really mindful of what kind of food intake he's able to handle cognitively and physically, or if absolutely necessary, we could even bring in a feeding tube if he's truly unable to intake food at all due to his confusion and delirium.
Yeah, I think that's a great point. We definitely don't want to complicate this patient more than he already is. As far as collaborative care goes, I think we really need to pull in a lot of different specialties for this patient because he does seem to be really complicated. I think it'd be a good idea if we pull in radiology just to get a CT scan, just so we can rule out any potential other causes for what looks like delirium, but we want to make sure that it's not anything more serious. We kind of also talked about that maybe some inadequate dialysis could be contributing to his delirium. And so we really want to make sure that they're pulled in on this case just to optimize his dialysis and monitor his blood urea, just because uremia can cause some encephalopathy, and that could be also contributing to his delirium. And also, I think pulling in, pharmacy, just so then that way we can help monitor his electrolytes and maybe look at his pain management and make sure that his dosing is really optimized for him.
And then some other obvious contenders that would need to be a part of this team would be both nursing and the neurologist and psychiatrist. The psychiatrist and neurologist would kind of help collaborate with nursing just to help oversee treatment and give recommendations. And nursing will work with the general management of the environment, care and mobility of the patient, kind of extending off of that OT and PT points that we discussed a few moments ago. A couple of other things that OT can do is work on sleep hygiene management because Mr. Ali has had trouble staying up at night. The better sleep he gets, the more likely it is to support the recovery of his delirium. And then secondly, reality orientation training, which is a cognitive intervention that deliberately and frequently orients patients to their time, themselves, and their surroundings. We'll definitely want to bring in a nutritionist and dietitian. They'll kind of work hand in hand with that speech language pathologist that we talked about earlier, because they're going to have really the rich insight on assessing the diet that Mr. Ali is getting. We don't want to forget about Mr. Ali's wife. So we definitely want to connect to the social worker and help her find those resources in the community. So be it a support group or be it educational resources that she may need for when he discharges home. I know we're not quite there yet, but working right hand in hand with her will be crucial to continuing to promote Mr. Ali's recovery.
Those are definitely great points. And I think it'll be great to transition to talking about his kidneys, especially considering the fact that he is on hemodialysis and has end-stage kidney disease. And one of the things that makes me concerned is his delirium and altered mental status, just as the neurology team mentioned. And perhaps it may be due to encephalopathy secondary to his end-stage renal disease. And just looking at his labs and chemistry, his bicarb is definitely low, which makes me concerned. His creatinine is elevated as expected for his ESRD. He does have hyperphosphatemia, hypocalcemia, and the CRP is elevated at 9.5, which makes me curious. So some etiologies that I'm thinking about are perhaps his uremic encephalopathy, hypoxic ischemic encephalopathy, and also septic encephalopathy. Another thing I am concerned about is his complications secondary to his kidney disease. Metabolic acidosis, possibly it's uremic or lactic acidosis. So maybe getting more labs and investigating the ANA and GAP would be helpful. And then electrolyte imbalances, such as his hyperkalemia, not really clinically manifestations are present. It is pretty high, but I think it should be something we should keep an eye out on, especially with his ESRD. He does have hypocalcemia and hyperphosphatemia, and I think his anemia could be secondary to his chronic kidney disease. So looking at his medications may be helpful.
Yeah, I totally agree with you. Now, our patient is on multiple medications. For his hyperphosphatemia, he's on sevelamer. For his hypocalcemia, he's on calcium. And for his anemia, he's on parenteral erythropoietin and iron sucrose 2 times per week. Now, we can definitely contact the radiologist regarding obtaining an EEG for the patient. We can also contact the nurses to obtain a urine culture to rule out any urine infections, and also monitor the hemoglobin, the vitals, the fluid volume status, and also have a discussion with them regarding, having a home nurse for the patient as a long-term care.
Yeah, those are good points. And also for his kidneys, we can get involved with nephrology and adjust and optimize his dialysis as needed, and maybe consider other options like continuous renal replacement therapy. For long term, I'm thinking for his hyperkalemia, if it does not resolve, then maybe adding paturimer may be an option. And I think it would be great to have the patient involved in the renal interdisciplinary care clinic for long-term management.
You can also contact the pharmacist regarding the holding of ACE because of his hyperkalemia. And we can also, contact them regarding any medication dose adjustments that would be needed for the patient.
I agree. And going off back on the long-term care with home care with nurses, I think we can also get occupational therapy involved with that as well. And the patient would definitely benefit from that. And nutrition would be great to talk to adjust his diet and make sure he is compliant with the diet that he's taking, maybe a low potassium, low sodium, low protein diet. And I think social work would definitely be super important so that we can discuss the financial support and access to healthcare to outpatient services as well.
Yeah, we would definitely be in touch with the cardiology team regarding the hypertension management, and also the transplant team to have a discussion with them regarding the eligibility of the patient for a kidney transplant.
And I think this would be also a good time to get palliative care involved so that the family can start discussing goals of care and advanced care planning for Mr. Ali. And I just want to touch upon a little bit on CRRT and its pros and cons. So some benefits is that it works very well in his hemodynamic stability. We can help him and support him for his nutrition as adequately as possible, and it is better tolerated. The things I am concerned, however, is that there is low mortality benefit for it, and it is quite costly.
What about peritoneal dialysis? Now, peritoneal dialysis would be less costly, and there's a reduced risk of hypertension with it. And also it would reduce the transportation burden on the wife. And the cons of peritoneal dialysis, are the increased risk of, peritonitis, protein loss, and non-compliance, which can lead to, further future complications.
All right, we must admit that the nephrology and neurology teams had a lot to say and contributed a great deal. However, we, the cardiology team, think that we are equally important, and we would like to contribute to solving this patient's issues. To start with, coronary artery disease is a major primary issue. The evidence for that was a total occlusion of LAD on the recent catheterization. This condition was a driver of multiple mechanical and conductive complications that we'll try to come across. So we have those secondary issues that are secondary to the primary coronary artery disease. As for the cardiogenic shock, it is a reduced ability of the heart to pump an adequate amount of blood necessary to maintain end organ perfusion. The guidelines state that a blood pressure of less than 90 is required. However, there's an exception that in a few patients, the raised systemic vascular resistance will maintain a higher blood pressure despite tissue hyperperfusion. So the manifestations in our patient were persistent hypotension, reduced ejection fraction, altered mental status, and the metabolic acidosis. Moving on, ischemic cardiomyopathy is a significantly impaired left ventricular function resulting from coronary artery disease. So it begins as an infarct that expands, and this puts additional stress on the surrounding normal wall, ultimately leading to ventricular remodeling. As for the mitral regurgitation, the evidence for that is a holosystolic apical murmur and the echo Doppler. I would like to add that such a mild to moderate MR is often clinically silent and rarely contributes to hemodynamic compromise. It is not of the major secondary issues, but it's a point to mention. Afterwards, polypharmacy. We have the dual antiplatelet therapy for acute coronary syndrome, trimetazidine for prevention of angina, and hypertension drugs.
I'll be talking about the collaborative care that is required by the cardiology team in specific. So the radiologist, we would have to perform or obtain a chest radiograph. The cardiology team nurse should obtain an arterial blood gas test, measure the serum lactate, and also retrieve the ECG. The cardiologist in the cardiology team should repeat the echocardiogram, provide inotropic agents such as dopamine, dopamine, consider pulmonary artery catheter and intra-aortic balloon pump and mechanical circulatory support devices. So the patient might not reach this situation, but in the long term, we would have to think about this in case. And we have to recommend a combination of sacubitril valsartan combination for management of hypertension. Now, this has shown to have more benefits for patients with reduced ejection fraction. And to the nephrologist, we'll have to say to address the anemia that would occur, and the pharmacist would have to temporarily stop all the antihypertensive drugs, avoid morphine as much as possible because morphine was seen to have interactions with ticagrelor, reduce the daily dose of aspirin to 75 to 100 mg, that is less than 100 mg daily, because more than 100 mg was seen to have a reduced efficacy, causing reduced efficacy of ticagrelor. Continue the ticagrelor 90 mg twice daily for a year, and after that, reduce the dose to 60 mg twice daily, and review the inotropic and sacubitril valsartan complex combination for a long term, recommended by the cardiologist. Occupational therapists should engage Mr. Ali in simple occupations and for physical and mental stimulation. Physical therapists should advise on reconditioning and energy conservation. Speech and language pathologists should continue. Nutritionists and dietitians should consider low protein, low potassium, and low sodium diet to reduce the potassium levels slowly and not aggressively. Social workers should ask the family, like that is the wife and the daughters of Mr. Ali, to support him financially and mentally, physically, emotionally, in all sorts. And finally, the transplant team and palliative care team would continue their care as such. And the cardiothoracic surgeon should assess the need as well as the fitness of Mr. Ali for AVT surgery and mitral valve repair. And finally, the psychologist and the psychiatrist should help Mr. Ali cope with all the mental effects and identify if depression is there at an early stage.
Great points, everyone. I'm glad we found some ways to address Mr. Ali's issues. Now, let's think about the future. How should we address this for future patients? Any ideas?
Oh, I can get that finished. So for the future, we have some strategies that we thought of. One is the interdisciplinary care clinic in CKD. So what that involves is basically a coordinated patient-centered approach in which multiple healthcare professionals from different professions, they educate and prepare the patient. So what is critical is the transition from CKD to ESRD. This transition is particularly a challenging time, mentally and physically. And this interdisciplinary care clinic aims to prepare the patient during this transition and for the various problems of RRT. And it has been shown to provide benefit in these patients. Secondly, cardiac rehabilitation is a comprehensive multidisciplinary program that is aimed to improve the health of patients with cardiovascular disease, not only the physical functioning, but also the psychological, vocational, and social functioning. This has been proven as well to provide benefits in terms of mortality, and the different comorbidities in this population of patients. At the end, this is our reference list. On behalf of Team 3, I would like to thank the organizing committee, and we are eager to meet you in the question and answer session soon. Thank you very much.